I'm Andrea Eidelman, and I'm the CEO of Debbie's Dream Foundation. Before we begin, I would like to acknowledge and thank Dr. Antonio Ucar for his leadership in bringing this event to the Miami Cancer Institute. Thank you also to the incredible team at MCI and the DDF staff for helping to make the event possible. The mission of Debbie's Dream Foundation is to raise awareness about stomach cancer, advance funding for research, and provide education and support internationally to our patients, caregivers, and families. Our goal is to make the cure for stomach cancer a reality. Pictured here is our founder, Debbie Zellman. DDF was founded by Debbie Zellman in 2009, 1 year after she was diagnosed with stage 4 gastric cancer. Debbie was a mother of 3 children, married to a physician, and practicing attorney at the time of her diagnosis. She had no risk factors for the disease, and her symptoms were very vague. Debbie was given a 4% chance of surviving 5 years after her diagnosis. Debbie faced many recurrences and harsh treatment options and lived 9.5 years with gastric cancer. Unfortunately, Debbie passed away in December of 2017. However, her legacy continues through the work that we do every single day at Debbie's Dream Foundation. To date, Debbie's Dream Foundation has funded $1,450,000 in gastric cancer grants. DDF partners with the American Association for Cancer Research to offer grants for basic, translational, and clinical research in stomach cancer to scientists at various career levels. Some of the ongoing initiatives that we offer our patient community are offered through our Patient Resource and Education Program, our national and international gastric cancer educational symposia, our gastric cancer webinar series, and our nutrition education programs. Our PrEP program is one of the largest programs that encompasses the general mission of the foundation to provide education and support to patients and caregivers internationally. The PrEP program includes our mentoring program, our advocacy and outreach, our virtual support groups, our Dream Makers Miracle Fund, our clinical trials initiatives and matching services, and our online support communities. As part of the PrEP program, we are able to connect those feeling alone in their diagnosis with others who know exactly what they're going through. Our mentoring program provides patients and families and caregivers and survivors and matches them with other similarly situated individuals based on age, location, stage, and biomarkers. Our monthly stomach cancer support groups are led by a clinical licensed clinician and are a great resource for all patients in their cancer journey. We also have online support discussion communities where patients can remain anonymous if they choose so and seek support and guidance from each other. Under our PrEP program, we launched our Dream Makers Miracle Fund to help wishes come true. Through the fund, we are able to send patients and their families on very special trips and create lasting memories for them. To the left, the Fitzgerald family was granted a trip to their Jersey Shore. Hattie was diagnosed with stomach cancer at the age of 54. Just after 10 years after being diagnosed with breast cancer. On the right, the Orth family was granted a trip to Yosemite National Park. Rachel was just 32 years old when she was diagnosed with stage 4 stomach cancer. We are able to grant family wishes, and we would like to continue to do so in the future. So please visit our website on www.wsdream.org to find out how you can apply for your wish, and we can make it come true. As part of our mission, we advocate for early detection and provide community education and support and outreach to physicians, nurse navigators, legislatures, and disparate communities affected by stomach cancer. We also have 32 chapters throughout the United States and internationally who are all strong advocates and help spread awareness in their communities about Debbie's Dream Foundation and stomach cancer. Each and every year, one of our signature programs are our national and international symposia, very similar to what we're doing here today with MCI. This year, our symposia series launched on February 9th with the physicians from the National Institute, NIH. The event highlighted the latest research in gastric cancer treatment. In June, we hosted our International Stomach Cancer Educational Symposia in partnership with the Korean Cancer Association. This event had more than 1,100 registrants from 41 countries and was translated in Chinese, Japanese, Korean, English, and Spanish. And it has been our highest attended symposia to date. And today, we are here at the MCI, Miami Cancer Institute, hosting our third symposia for 2022. Each year, we also host 4 to 6 webinars on all the topics that our stomach cancer community wishes to know. These topics include the latest in clinical trials, treatments, surgical options and techniques, immunotherapies, and many more. Be sure to stay tuned for our upcoming webinars in September with clinical trials updates, and in November, we'll cover various topics with the experts at the Rutgers University. Stomach cancer patients and caregivers need simplified answers to help them maintain proper nutrition, both pre and post gastrectomy. We offer education around nutrition through our webinars, symposia, recipe books, and content from our website to help empower our patients. Emmy-nominated Chef Nathan and clinical oncology dietitian Mary E. Brown from Johns Hopkins University are leading this year's live cooking demonstrations, preparing delicious meals that are modified for gastric cancer patients. Please visit our website for our next event that will be hosted in December around eating around the holidays. The foundation has offered many new initiatives, and one of those initiatives is through our health equity program, where we are offering a free cancer care helpline to patients so that they can connect with licensed oncology social workers and be connected with all resources that are offered to our communities. We also offer a Mind, Body, and Spirit webinar series that discusses other modalities for survivorship, such as yoga, Tai Chi, meditation, and many more topics. All of our programming is reviewed by our esteemed Scientific Medical Advisory Board. These members host webinars and symposia at their various clinical institutions throughout the year, and for that, we are very grateful. DDF also hosts many events throughout the country, which include a multitude of golf tournaments. We also host one here locally each and every year in the spring. We will be hosting another one in 2023 in partnership with the Broward County Medical Association. And to learn more about those, you can also visit our website. Our next local event will be in Fort Lauderdale, Florida, and it will be our Legacy Brunchin. The date of that event is Sunday, December 4th at the Broward County Huizenga Pavilion, and we hope that many of you folks that are here locally will come and attend and eat delicious food and help support our mission. To keep up with all that DDF has to offer, please find us on social media using the social handles listed here. We'd love to connect with you. Thank you again for listening. Thank you again for tuning in. And thank you for those that are participating, all the physicians that are also will be speaking today in this wonderful event.
Thank you, Andrea. We're proud to partner with David's Dream Foundation to offer this important resource to patients and community. Now, I would like to welcome our first presenter, Dr. Fernando de Saraga. Dr. de Saraga is a medical oncologist at the Miami Cancer Institute, where he works as a gastrointestinal cancer specialist. He received his medical degree from the University of Miami Miller School of Medicine and completed residency in internal medicine at the University of Miami. Jackson Memorial Hospital, where he also did a fellowship in hematology and oncology. He's board certified in both hematology and oncology. Thank you, Fernando.
Thanks, Dr. Ucar. And thanks everybody for hosting and for having us be part of the presentation today. So I'm gonna talk about gastric cancer, and specifically the management of early stage gastric cancer. We can advance to the next slide. So we've heard about So we've heard about just how this disease can affect us, and it can be a significant burden for all of us. In the latest numbers indicate that there's about 27,000 cases in the United States per year, and just under half of that in terms of unfortunately deaths, and that's in part due to how advanced this disease generally is when patients present. So you see here there's generally a high mortality rate because patients tend to present in a more advanced state. If you look at the survival numbers, even with early stage disease, which is stage 1, completely resected, everything has been removed, the 5-year survival rate is about 70-75%. Unfortunately, drops to 35% or less when we're talking about stage 2B disease or beyond. And over here in the left, we can get I just put for reference purposes, we're looking here at the stomach. The esophagus comes down, it joins the stomach, and then there's the body of the stomach there. So we're going to be focusing on the stomach, the body of the stomach cancer, right after the junction to the esophagus today. Next slide. So as with most cancers, what we want to achieve and what we're trying to accomplish is to take out the tumor, right? We want the tumor to be taken out, and there are a number of ways in which we can do that. Surgery, of course, is one of them. We'll talk about other strategies when the tumor is very early on, but the bottom line is we want to take out the tumor, and so we want to improve outcomes over what we have today. And so many of the studies that we're doing today serve the purpose of trying to improve results beyond surgery alone, whether that be with treatment after surgery, or treatments before surgery, or combinations of treatments, both pre and post, and different types of medicines, which I'll get into as well. But the bottom line is we know we want to take out the tumors, and we want to continue our endeavor to try to improve outcomes beyond surgery by complementing surgery with other types of treatment. And we know that we can have an impact on survival if we do this. We've seen positive impacts over time, but there hasn't really been a best approach, at least a consensus best approach yet. So the studies continue. Next slide. So this is a dated slide, and it's a busy slide, but I put this in there just to emphasize. So when we see patients in the clinic, one of the first things we want to note is what the stage is, and I think that most patients are familiar with what the stage is, and that's probably the number one question that I get asked when I see patients is, what's my stage? Where am I? So staging is important for a number of reasons. I mean, it's basically a snapshot of what's going on right now. It tells us the extent of disease right now, and that really is summarized by 3 letters. The TNM system. The T refers to the tumor size and penetration, as we can see here. N refers to whether there's any lymph nodes or not, and M refers to spread. Is there any spread beyond the stomach or not? And so it's very important. It not only gives us a snapshot of what's going on right now, but it also has implications for risks of recurrence, and therefore for how aggressive we want to be in terms of treatment. So I already mentioned, what we want to do is we want to take out the tumor, but patients that have more extensive disease, that have positive lymph nodes, et cetera, their risk of recurrence is higher. And so we know that we have to treat those patients differently in order to improve their outcomes. Next slide. So again, focusing on stomach cancer, when it's very early on, and that's that tumor that's T1, as I showed in the previous slide. So when the tumors are very at the very beginning, it's a T1 lesion. That means that it's limited to the mucosa or submucosa. That's what we call early stage or early gastric cancer. And for those cancers, the goal is no different. The goal is to take the tumor out. But when the tumor is so small and localized to the mucosa or submucosa, some patients can be spared surgery. So for some patients, for some appropriate patients, we can send them to the gastroenterologist, and they can have, go back to the previous slide, and they can have an endoscopic resection. So they can have the tumor removed through an endoscopy and not necessarily through surgery, which improves morbidity, can improve recovery time, et cetera. So that can be appropriate for some patients. For some patients, if the tumor is too large, if it's too extensive, if it extends beyond the submucosa, if there are lymph nodes involved, for some patients, an endoscopic resection isn't possible. And so again, in keeping with the goal of removing the tumor, for those patients, we send to surgery. And so that surgery can vary, and we'll hear from the surgeon, from Dr. Jimenez later on, but that surgery can be some type of gastrectomy, either partial or total, depending on the location of the tumor in the stomach. But at that point, if the patients go on to surgery, they have some kind of gastrectomy with removal of lymph nodes. And again, what's been achieved there is the tumors come out, the lymph nodes have come out, so hopefully all of the disease is out, and it gives us a better idea in terms of staging, because the lymph nodes have come out as well. And so, we have better information, better data, and so we can act in better ways to improve outcomes. Also important is if patients are found to have H. pylori, which is the bacteria that I think most of us are familiar with. It can cause gastritis, can cause ulcers, but it can also lead to the development of metachronous or different gastric cancers at different points in time. And so it's important, if H. pylori is detected, to treat it and get rid of it, as that can decrease the risk of developing a different gastric cancer later on, especially after treatment of early gastric cancer. Next slide. So when tumors are more advanced, when it's beyond early, so we're talking here about tumors that are T2 or greater, and this is something that your doctors will note and will let you know. But for those patients, endoscopic resection isn't felt to be appropriate, and so those patients go on to have surgery. And so the question is, how can we improve outcomes beyond surgery? And so, as a medical oncologist, multiple studies have been done to try to show how we can improve outcomes, and that can be done a number of different ways, whether it be treatment before surgery, and we call that neoadjuvant therapy, or treatment after surgery, and we call that adjuvant therapy. But basically, for tumors, if we can get back to the so for tumors that are T2 or higher, we generally start a treatment with systemic therapy or medicine before surgery. There are several advantages to this. When we give treatments before surgery, generally it's easier. So patients, before surgery, patients are generally healthier. They haven't had surgery, so they're not recovering from surgery. And so it's easier to deliver chemotherapy before surgery. So that's one of the advantages of giving it beforehand. We can also deliver therapy in an effort to improve the tumor, make it smaller. And so we can perhaps make a tumor that's bigger, smaller, and make it easier for the surgeon to remove at the time of surgery. And there are some patients, unfortunately, that have gastric cancers that will behave in a very aggressive way. And so if those patients were to go on to surgery, they would go through surgery, and they would have a pretty extensive surgery, a pretty morbid procedure, and perhaps develop more advanced disease in short order because their tumor was so aggressive. And so giving people treatment before surgery allows us to sort of select out those people who would probably not benefit from surgery. And so we can direct them to other treatments that can be effective and spare them the morbidity of having undergone a surgical procedure. Either way, when we're talking about delivering treatment before surgery, we generally send people for a laparoscopic evaluation before. So the surgeon performs a laparoscopy before, just to confirm the amount of disease that we're actually talking about, and then we get started on treatment before surgery. Next slide. So again, treatment before surgery generally recommended for T2 tumors or greater. The regimen that we generally use is we know it as FLOT. It's a combination of several medications: 5-FU-leucovorin, oxaliplatin, and docetaxel. And it's important to note that that treatment is given both before surgery and after surgery. So in patients that begin that regimen and then go on to have surgery, should always try to complete the part of the treatment after surgery, if possible, of course. If there are issues with tolerability, because that regimen can sometimes be fairly strong, then we have alternative regimens as well. You see here a couple of them: FOLFOX, CAPOX. But in general, the strategy is give chemotherapy before surgery, then go to surgery, and then give chemotherapy after surgery. In some cases, although not considered standard, but in some cases, if at the time of surgery, it's felt that patients that the chemotherapy before surgery didn't really work very well, and patients have extensive residual disease, or they have positive lymph nodes, then we can ask our radiation doctors to see if it's appropriate to complement the chemotherapy that we're going to give by adding radiation. But that's for select patients. Next slide. So that's if we start with treatment before surgery. So sometimes patients go straight to surgery, and if that's the case, then we give, on the medical oncology side, we give what we call adjuvant therapy, or treatment after surgery. And that's generally recommended for patients that have positive lymph nodes, or patients that have T3 to T4 disease. Most of the time, if we're giving treatment after surgery, that treatment consists of just chemotherapy. And there are a number of regimens we can consider, but we usually consider something like capecitabine and oxaliplatin. We call that CAPOX. Some patients that haven't had what we call an optimal lymph node dissection, or enough lymph nodes removed, or who have extensive disease, can go on to also receive chemotherapy and radiation. And this emphasizes something that's very, very important, especially in early stage gastric cancer, is the collaboration between all different specialties. The collaboration between the surgeon, the medical oncologist, the radiation oncologist is really critical in the management of this disease. And so it's important to have, to be in a place where your doctors all collaborate and get together and discuss, either formally by way of a tumor board, as we do at the Miami Cancer Institute, or otherwise. But the collaboration of all of the specialties is very important. In general, after surgery, when we're giving treatment, it's approximately 6 months of therapy, however it is given, whether it's chemotherapy alone or chemotherapy and radiation. Next slide. For some people, the tumor is advanced locally, so it hasn't yet spread, but it is advanced locally to where it's not felt to be resectable at all. And those patients are challenging, and we're still trying to figure out the optimal approach. But a reasonable approach is, again, borrowing on the concepts that I already introduced, is to try to give some treatment up front, whether it be chemotherapy or chemotherapy and radiation, in an attempt to shrink the tumor, and therefore perhaps make it feasible for the surgeon at some point to be able to operate. So, these approaches are still being worked out, but depending on the patient and how young they are, how aggressive they want to be, how aggressive we think we can be, then all of those strategies are generally considered to be appropriate. I think looking forward, I think the important thing for early stage gastric cancer is the importance of getting all the specialties involved. So not just medical oncology, but surgery and radiation, and continuing our endeavor to try to figure out ways to optimize the treatments that we give both pre and post surgery. So we've talked about chemotherapy here, but looking forward at the clinical trials that are currently being done, that we hope will certainly change the standard of care in a better way, as we're beginning to incorporate immunotherapy options as well to chemotherapy options, as well as other biologic therapies, VEGF inhibitors, as an example. So the future looks bright, and we will continue to try to optimize our approach and collaborate with our partners to try to improve outcomes. And I believe that's the final slide. Yes, thank you very much.
Thank you very much for the excellent presentation, Fernando. We have a few questions from the audience, so I'm going to read them to get your opinions. So the first question is, what should I ask my medical oncologist during my first appointment?
Yeah, so it's a good question, and this is a cliche answer, and I know that everybody in this presentation has heard it, but there is no dumb question. I would start by saying anything that comes to your mind, you should absolutely ask. Even if it's not on the first visit, what I tell my patients is, if something pops in your head, write it down. Even after that first visit, write it down, bring it with you on your next visit, and we'll try to address everything. More relevant to stomach cancer, as I mentioned, stage is something that patients always ask about. So what's my stage? What are the treatment options? It's always appropriate to ask about second opinions. The second opinions. So when I take care of patients, I show them so there are national guidelines on how to manage these patients, and so I try to show the patients what the guidelines are to try to make them feel comfortable, and those guidelines are very, very important. So and I direct them. There's a patient section, and they sort of dictate how we manage patients. And so all of those things are important. Stage, treatment options. Who else should I see? When can we get started? Obviously, and what's my potential outcome? I mean, I think all of those are the relevant questions that I would ask if I was seeing a doctor for the first time.
Okay, thank you. Since we have time, we're going to go with several questions. So we'll go to the next one. If I have suffered from gastritis for a long time, what can I do to lower my risk of gastric cancer? Yeah, so gastritis can be caused by a number of things, right? It could be caused by medications. Some people just have gastritis. Some people have what's called Barrett's esophagus, which can increase the risk of developing gastritis. I mentioned H. pylori. H. pylori is probably one of the main things that we can do to decrease our risk of gastric cancer. So, I guess the most appropriate and relevant way to answer that question is there are many people who have gastritis, who suffer from chronic heartburn, and just think that it's normal, and just never probably don't seek attention. And I would say that's probably not the best approach. Having chronic heartburn is not a good thing.
you should absolutely see your gastroenterologist. It needs to be the reasons for the heartburn and for the gastritis need to be investigated, because there are ways of reducing of number one, improving symptoms, which is what you want before you get cancer, and what's relevant, but improving those by treating the cause and improving those symptoms, that will hopefully lead to a decreased risk of gastric cancer, primarily through H. pylori eradication.
Okay, thank you. So let's go with another question. What are some of the warning signs of gastric cancer?
So, unfortunately, and this is, I mentioned at the beginning, most patients present with advanced disease, and it's because there aren't any reliable early warning signs. I mean, there are symptoms of heartburn, but there are many people that have heartburn that don't have stomach cancer. There are some digestive issues, but everyone gets GI issues every once in a while. I think that screening, in terms of knowing what will lead to stomach cancer, I think that's difficult. But I would say any issues with digestion, any issues with subjective, feelings of heartburn should prompt a visit. We should never assume that these symptoms are normal, especially if they don't go away. But heartburn, problems with digestion, difficulty swallowing, getting full, feeling a sensation of feeling full very early on, weight loss. These are things that can happen to anybody and don't necessarily mean that there's stomach cancer. But rather than trying to justify all of these things in our head, I think it's best if we go to the doctor early on and hopefully go down the right path in terms of evaluation.
Okay. So for the next question, I'm going to paraphrase it. I would say this is a question that is asked a lot, and basically wondering why it is recommended to have colonoscopies beginning at age 45, 50, and yet we don't have a recommendation for open endoscopy for screening of gastric cancer.
Yeah, so I think that I think that colonoscopies for sure are recommended. The age recently came down from 50 to 45, and I think it's because it's been proven to be a reliable screening method, and it can certainly detect cancers at an early stage. The incidence of colon cancer or the prevalence of colon cancer is also much higher, and so we can have a much greater impact when we screen for patients and try to detect early on. And the age of stomach cancer the age of colon cancer, the age at which patients get colon cancer has also decreased. So I think for all of those reasons, colon cancer has really become a staple and very, very important as a screening test. In terms of screening for stomach cancer, I mean, I think the incidence of stomach cancer, overall, stomach cancer is not as common a disease. I mentioned 26,000 cases per year. And as I mentioned before, there's no reliable symptoms. There's no reliable ways in which we can predict whether somebody's going to get stomach cancer or not. And so as a result of that, I think that the recommendation is not to be proactive, rather wait for somebody to develop symptoms and then perform an endoscopy. I don't know that I think there are different ways in which we're looking at screening for cancers beforehand. And I think that's coming in the next probably decade or so, but screening via endoscopy probably is not there yet. As the impact probably won't be as great as we have with colon cancer.
Yeah, just to add to your comments, I think that one of the keys is exactly that the frequency of gastric cancer is not as high in the United States as it is in other countries in Asia and South America, for example. In Japan, Korea, and also in Chile and Venezuela, they have screening programs because their frequency of stomach cancer is much higher than what it is in the United States. And they usually include upper endoscopies every couple of years or x-rays with barium to detect small lesions in the gastric lining. But I think that in the United States, we're not there yet. And I agree with you that there will be new ways to detect it early that will be recommended in the next 10, 20 years. So let's go to another question, perhaps the last question. Is a diagnostic laparoscopy only performed for stage 2 and under?
So, the laparoscopies, are, we recommend, and I'm sure the surgeon, when we hear from Dr. Jimenez, he'll mention this, but all of this, whether it's CT scans or PET scans or laparoscopy, I mean, these are all efforts to try to ensure as best we can that the amount of disease that we think we're dealing with is actually accurate. And so it's a way to, it's the best ways that we have of making sure that patients have early stage disease and that they are appropriate for the strategies that we use when we're trying to get patients, when we're trying to treat patients for early stage disease, whether it be T2, T3, et cetera. So the imaging gets us information about spread beyond, and the laparoscopy gets us information locally and in other more difficult places to prove whether there's disease or not. Part of the laparoscopy is to sample the peritoneum, sample the abdominal cavity, and so they're all strategies to try to guarantee that the stage that we're working with is the appropriate stage and is the accurate stage. And if we do that, then we can treat patients appropriately and improve outcomes.
Great. Well, we'll go to the last question. If you can answer it in a minute, Fernando, that's your challenge. So what are recommendations for gastric cancers that cannot be surgically treated? For example, a patient with metastatic disease, and what are some palliative care practices? Yeah,
so what I focused on in the presentation was early stage cancer. So these are cancers that are localized still to the stomach, perhaps with lymph nodes. But towards the end of my presentation, you may have heard, you may have seen, there are some patients that are not felt to be resectable, that are felt to not be able to have surgery at the beginning. And while there's no, consensus way on how to approach those patients, it's reasonable to try to be as aggressive as possible, depending on the patient population and how aggressive we want to be and how realistic we think it is to get them to surgery. We can still sort of proceed forward and have surgery as a goal by combining chemotherapy and radiation. For those patients that have disease outside of the stomach, in that TNM staging, that would make the M a 1. That tumor, unfortunately, has spread beyond the stomach. Those tumors are treated completely different. We generally start with medicine. We incorporate other, it's not just chemotherapy. We incorporate other options like immunotherapy, like biologic therapies, for example, Herceptin, targeted therapies. And that's a different scenario altogether. You'll hear from Dr. Aparo in a bit, and Dr. Aparo is gonna delve into the treatment for metastatic disease in a much deeper fashion.
All right, thank you very much. Great presentation.
Thank you all.
Thank you. Let's move to the next presentation. Dr. Ramon Jimenez. He's our excellent surgeon. He's a surgical oncologist and chief of the Division of Melanoma and Soft Tissue Sarcomas at the Miami Cancer Institute. He has been in practice for more than 20 years. He's getting old and has extensive experience in the surgical management of complex tumors. His area of expertise includes melanoma, soft tissue sarcoma, and also upper gastrointestinal tract malignancies like gastric cancer, where he has a particular interest, and also hepatobiliary and pancreatic tumors. He collaborates with the MCI's multidisciplinary team of cancer care specialists to provide the most effective treatment plan for each individual patient. He's going to speak about robotic surgery for gastric cancer. Thank you. Ramon?
Good morning. Thank you, Tony, for organizing the symposium, and David's Dream for getting involved in this, as these are not very common topics. Usually most of the funding and the research goes to the common diseases like, you know, breast cancer, prostate cancer, colon cancer, and these other cancers get put on a second plane and don't get as much attention or research money. And so that's really important that we organize this. The picture here is me with Bella. Bella is a canine volunteer at Miami Cancer Institute, and there's always questions for the audience: which one am I? And I'm the one with the black hair. Okay, so move on to the next slide, please. As Fernando mentioned, the stomach has multiple parts. So we have the stomach begins at the end of the esophagus, and we call it the gastroesophageal junction. The very top part of the stomach is called the cardia, as it's close to the heart. The fundus and is the very apex of the stomach. The body is the majority of the stomach, and then at the bottom you see the antrum and the pylorus, which is a valve that keeps flow going, integrate towards the small bowel. But in general, gastric cancer can occur anywhere in the stomach from beginning to end. And that's important for the surgeon because not all gastric operations are the same or have the same complexity to them. So I will tell you, for starters, when the tumor is at the junction of the esophagus and the stomach, that's a really tough area, because oftentimes to get the tumor completely removed, as we call negative margins, you actually have to remove a segment of the esophagus, and then you're extending the surgery into the chest, and that's major. The second area where it's difficult is when you're working at the very bottom of the stomach, at the pylorus and into the first portion of the duodenum. The issue there is that the duodenum, the first portion of the small bowel, doesn't have a lot of mobility. The pancreas is in that area very close, and sometimes to be able to remove a tumor from that area, it requires an extensive operation that would also remove a segment of the pancreas and all that. So luckily, I have to say that most of the tumors that we see are in the body of the stomach, so that we do have most options open for the majority of patients. Next slide, please. So some of the things that are important here from a surgical standpoint now, Fernando discussed very thoroughly about the workup and the evaluation of the patient for treatment options, but these are more issues that the surgeon is concerned about. So one of the things that Fernando mentioned, and we were discussing in the questions, is that there is no screening program for gastric cancer here in the United States. And that is important because when you read the literature, the medical literature on gastric cancer, you see all these articles on early gastric cancer and endoscopic management. So no surgery, just by endoscopy, removal of tumors and all that, that is done very often in Japan and Korea and countries where they have a lot of gastric cancer, and they have the screening programs where they're able to detect very early disease. We don't have those programs here. So my experience with EGC, early gastric cancer, is almost zero. You never see that. It would be very rare. At most, we see, somebody who had an ulcer and has some dysplasia or, precancerous changes, but the T1, very superficial early gastric cancer, we rarely see that in this country. Most people come in with symptoms, as Fernando mentioned, some weight loss, some anemia, some reflux, et cetera, et cetera. And then once symptoms develop, you know that this disease is not early anymore. The second point I make here is that there are two types of gastric cancer. There's a diffuse type and there's an intestinal type. The difference is this: the intestinal type of gastric cancer usually forms a lesion. So there will be an ulcer, or there will be a mass, or there'll be a focal spot where the patient was bleeding, or where the gastroenterologist picks up something on the lining of the stomach, what we call a mucosa. Those are, you can see those mostly in the older population, and also they have a better outcome in general. The diffuse type of gastric cancer is more tricky. Usually there is no lesion, there is no ulcer, there is no mass, there is no narrowing. So what you get is basically that the stomach wall gets really thick, and many times it's difficult for the gastroenterologist to be able to make the diagnosis, and so there's delay in diagnosis, number one. Secondly, these tumors tend to be more than you see, so that in many instances the entire stomach is involved, and obviously that's cutting down some options to save the stomach when we're doing surgery. And then lastly, the diffuse type of gastric cancer is the type of gastric cancer that you would see in families who have that as an inherited genetic syndrome. So you have to be very careful when patients come in with symptoms and they don't have a diagnosis, that you're not dealing with that. Fernando mentioned about staging laparoscopy. Yes, staging laparoscopies are done as part of the evaluation of the patient before starting treatment. And the issue here is that some gastric cancers can spread by what we call exfoliation. That would be like cells basically detach from the primary tumor, and then wherever they land, they grow. So they can grow on, say, the surface of the small bowel, on the surface of the liver, on the surface of the lining of the belly itself, which we call the peritoneum, or the omentum, which is a fatty apron that is in the belly. Anywhere you can have this exfoliation, and what we call carcinomatosis, little dots of cancer. And for those patients, unfortunately, we know that surgery doesn't help. So for me to be able to identify them early is excellent in terms of like being able to do the right chemotherapy from the beginning and not bring up surgical options that may not be appropriate, and give anybody false hopes. And lastly, as was mentioned also in great detail, lymph node involvement, and as I'll show you later on in the presentation, lymph node involvement is very common for gastric cancer. And so many times when you detect the tumor, it is already in the lymph nodes. These are the patients that we know benefit the most from receiving chemotherapy. And so that's why it makes sense, as Fernando mentioned, that most of the patients that present with more than T2 disease are treated with chemotherapy before surgery. Next slide, please. In this slide here, my aim was to show you, there's the stomach again, and you see all the lymph nodes that are involved. There's a number of perigastric lymph nodes that you see in blue and light green on both the right side, that's called the greater curve, and the left side, the lesser curve of the stomach. But there are other lymph nodes by the junction of the esophagus and the stomach, and also by the pylorus, the valve at the end of the stomach leading to the small bowel. And these are the lymph nodes that are basically along the stomach wall itself. But there are lymph nodes that are also important behind the stomach, and those are the ones in the lower panel. These are lymph nodes more now in the arteries that supply the stomach and the adjacent organs, being the liver and the spleen. And those lymph nodes are also, for the most part, removed during the surgery. It is important to realize, there are a lot of gastric operations done. There are gastric surgeries done for, acid reflux. There are gastric surgeries done for benign bleeding ulcers. There are gastric surgeries done for special tumors that do not go to the lymph nodes. And there are gastric surgeries that are done for weight loss, bariatric surgery. And when you do all those surgeries, you have no responsibility to be removing these lymph nodes that I'm showing you here. However, when it's a cancer surgery, you have to clean all those lymph nodes because if you leave the lymph node behind, you're leaving disease behind, number one. But secondly, in order for us to determine staging, as Fernando mentioned, that end stage, that nodal stage, depends on you having removed at least 15 lymph nodes. Otherwise, the information will be considered inaccurate or incomplete. So these surgeries are a lot more complicated than the regular surgeries or the more common surgeries that are done for gastric cancer. This requires more effort. Okay, so next slide, please. Now, basically, there are a number of surgeries that we do for gastric cancer. I'm not going to go into the great detail of all of them, but I will tell you that 90% of the surgeries that are done are either subtotal gastrectomies in this slide right here, or total gastrectomies in the next slide. Those are the two most common. These are the ones that everybody basically has to be familiar with. In the subtotal gastrectomy, which is the more common surgery that we do, basically, we remove about 75% of the stomach. I know in my graphic here, it only shows about 50%. So in my graphic on panel A, you see the shaded area that includes the bottom half of the stomach is what is going to get removed. We usually do a little bit more than that, like 75%. And that allows you to get all those lymph nodes out that I had mentioned before. But basically, the bottom part of the stomach is what's being removed here. And we save a remnant, the cardia, a bit of the fundus, as I had mentioned in the prior slide. Leaving just a little bit of the stomach makes a huge difference for the patient. First of all, I feel that when a little piece of the stomach was saved, patients always eat better. In addition, you're preserving the sphincter at the bottom of the esophagus, so people are not they're not bothered by reflux as much as when we do the total gastrectomies. And because people eat better, they maintain their weight better. And in general, most people, when you talk to them, after 3 to 6 months from the operation, they eat normal. They don't really bring up any issues. For the surgeon, this is the less complicated operation. And so that it's not as stressful as maybe the other ones that we do. In panel B of my illustration, I don't have a pointer, but in panel B, you can see the different ways that you can reconnect the gastric remnant with the small bowel. And the connection that you make really depends on how small is the remnant left behind. If you leave a really small remnant of stomach, you may want to consider doing the more complicated reconstruction panel D on the right-hand side, because that decreases the amount of bile refluxing into the stomach, which can give, a weird taste in the mouth, and it has a number of other side effects. So there's multiple ways of reconnecting things back together so the patient can resume normal eating. Next slide, the alternative to the subtotal gastrectomy is a total gastrectomy, which is this one here. Basically, the entire stomach is going to get removed. You see in panel A, there's a whole stomach in there that is sick, let's say with a diffuse type gastric cancer that I mentioned before. And in panel B, you see how the stomach is gone. And then you have reconstructed the small bowel to replace the stomach. So the esophagus has been connected to the small bowel, and that's how you would eat afterwards. Again, what are the issues here? The issues, first of all, working with the esophagus, it's very difficult. The esophagus doesn't have a lot of leeway, so you can't really manipulate it very much. There is a space constraint, so the esophagus tends to retract into the chest. So when you're working from the belly, that thing is pulling away from you, and there's always an anxiety that it's gonna go away into the chest. So that's unnerving, to say the least. And then those connections that you make between the esophagus and the small bowel, even though they look there, you just put it back together, they can be very technically demanding. So these are very complex operations. The esophageal connection, or anastomosis, as I mentioned in there, today has been improved by a circular stapler that was developed, and that has, I would say, facilitated doing these connections and made it easier for the surgeon and the patient to recuperate. But in general, when we do these surgeries, as you see in panel B, we put in a little feeding tube because people have trouble resuming their oral nutrition. This surgery, in my experience, and I think all of us experience, people lose weight and they can't put it back on. And sometimes it can be a lot, like 30 pounds. So to the point that you have to get a whole new wardrobe. Your clothes doesn't fit, and it's not going to fit. So it changes your appearance. When you eat, it can be difficult in terms of like having to have multiple small meals through the day, as opposed to just the general 3 meals. If you sit down, you can't finish a plate at one sitting because you feel full early. That's called early satiety. And so there are issues with maintaining weight and eating. And so that's why, this surgery, we reserve it for when it's absolutely necessary. But for some people, this is what they need, and this is what saves their lives. And so that's what we need to do. And one thing that is not often commented is that when you do this surgery, you're going to be removing the sphincter between the esophagus and the stomach. So people end up with this chronic reflux. For many patients, that means they can't even sleep flat in bed anymore. So they always have to sleep with a 30-degree or 45-degree angle. And that, at the beginning is fun, but then, after a while, that's not fun anymore. And maybe you have to get one of these beds that are, that raise the back. There's a bunch of them that I see advertised these days, or, more money. So these are the issues here with the total gastrectomy. Next slide, please. Now, all of these surgeries obviously were worked out in many years ago, and they were what we call open procedures, traditional surgery. This machine that you see here is the Vinci Robot. Whenever I mention the robot, I always when I look at the patients, I feel that the human mind, I think people think that there's this humanoid figure that's going to come in and operate them, like C-3PO from Star Wars. But this, as you can see here, is not humanoid, and for me it looks more like a spider. But basically, on the left-hand side, this is called the surgeon console. I'm sitting there, and you see that I'm not even close to the patient, and I could be in another room. This in the surgeon console, I am controlling the arms of the robot that you see on the right-hand side. This is a real picture of a patient here in position for a gastric surgery. The legs are split so that the assistant can sit in between the legs and help with instrument changes and suctioning and a bunch of other activities that need to be done at the bedside. But I'm not at the bedside, I'm at the console. If you see from the top, there are 4 arms labeled 1, 2, 3, and 4. Those are actually the arms that come into the patient to do the surgery. One of those arms is a camera. So it's not an operating arm, it's the eyes, so that I can see basically what we're working on. But it gives you the option here, as you can see, that there are 3 arms. I only have 2 arms, so now you have 3 arms. And so this machine it makes you superhuman, as I call it. And not only that, I will tell you that when I do conventional open surgery, I'm right-handed, so I always prefer my right hand, and I have more dexterity on my right hand just by the nature that I'm right-handed. With this machine, it makes you ambidextrous. I've never been able to put a stitch with my left hand in an open case. Never. I have no control of it. I don't feel safe, and I don't do it. But with the machine here, you can work with your left hand as good as you can work with your right hand. So the machine actually has a number of technical advantages to doing the traditional surgeries. Now, the next couple of pictures, ladies and gentlemen, are some videos of surgery. I know it's Saturday and it's breakfast time, and some people, they don't like to see blood or stuff like that. There is not a lot of blood in there, but there's tissues, and this is not for everybody, I realize. So if you want to turn it off for a moment, don't feel bad about it. Okay, so next slide, please. Okay, and press play. This is what I wanted to show you here, is that instrument that is moving there is a sealer, a tissue sealer and divider. So in the past, or in open surgery, you have to put clamps and make ties and all that. With this instrument here, it basically seals the vessels and cuts them in the middle, and it saves you a lot of time. But you can see that you're keeping a very bloodless field and doing your dissection. At 12 o'clock, the thing that you see at 12 o'clock is the stomach. And I am separating the stomach from the colon, which would be at 6 o'clock in the picture. Here I am behind the stomach is being pulled up. I am separating the stomach from the pancreas, which is what you're seeing in the bottom, being pushed down. So basically, this is the first part of the operation, which is mobilizing the organ, separating the organ from where it's attached to. And that's usually the colon, the pancreas from behind, the spleen on the left-hand side, et cetera, et cetera. In the next video, no, that's the same video. Next slide, please. Okay, in this video, my purpose was to illustrate for you. Many people ask me, the patients ask me, Dr. Jimenez, how do you divide the stomach? This is it. This is a stapler, a tissue stapler. You saw it there? So basically, I put it across the stomach, and it created a staple line. So that little instrument places staples on each side of the division, and then cuts it in the middle. So not only are you dividing, but you're sealing each side also. This is a surgical stapler, and you can use it with a robot also. Here's another firing going on as I'm coming across the stomach there. These are the surgical toys. They're fantastic. Super accurate. This is precision surgery. And as I mentioned before, we used to do all this stuff by hand before. And now with these instrumentations, you can go quicker. You don't depend so much on your technical skills. And so I always say, when people ask me, why don't you hand sew it? And I always say, well, let me tell you something. If you have to compare a human sewing something versus the machine stapling it off, I guarantee you the machine does a better job. It's just flawless. Humans are error prone. Next slide, please. This is my last slide of blood. I apologize for those of you who don't like this. So this for me is the reason I love the robot. This is what I was mentioning before, being able to work with both hands. This is intracorporeal suturing. So this is suturing like I would do in an open case, now with the robotic arms. You can see that I grab the needle exactly like I would do in the open case, pass it through, put it to the other side. These are special sutures that have been developed that are for minimally invasive surgery, whereby the suture holds its pathway, and so it's not loose, and it allows to work with precision, fast, and equivalent at least to the open procedures. So those are some of the toys that we use to get these things done robotically. You can't do all the surgeries robotically. You have to have clinical judgment. But for a lot of the patients, this is very applicable. Robotic surgery has been around for at least, I would say, 20 years now. The initial application of robotic surgery was really for urology, prostatectomies. From there, it also went to GYN, where a lot of the hysterectomies today, more than 80% are done robotically. And so general surgery and surgical oncology have been latecomers to the robotic surgery revolution. I would say most of us that got involved early with this, like myself, we've been working on this really for the past 5 to 7 years. So it's been, for me, this has been fantastic, and it's given me like a second life in surgery, I feel, and I feel like I'm young again, and I'm learning all these things, and I'm up with a young crowd, and it's nice. Okay, so next slide, please. No, that's the same one. Okay, here. I wanted to show you this here. These are from our team, from our Miami Cancer Institute that I'm a very proud member of. I joined Miami Cancer Institute, for those of you who don't know. It opened on January 2017, so we are a new venture here in Miami. So I can't show you here 20 years data because it doesn't exist. But I've been here from the beginning with my colleagues, all of us in the gastric surgery team. This is from April 2018 to July 2022, so this most updated data. And 79 cases, 80 cases of gastric surgery. Half the cases, as you see there, are for adenocarcinoma. That blue is gastric cancer. We do other gastric surgeries, as I mentioned before, but we're talking here today about the blue, the 53% that you see right there, which is for adenocarcinomas. So about half of 80 is 40, right? And you say 40 cases. Yes, 40 cases. That's a lot. Because remember what Fernando said. There's only 25,000 cases of gastric cancer in the United States per year. You can't ask me to have a volume, as I would have said, for example, for breast surgery, where there are 10 times more cases, 250,000 cases of breast cancer in a year. And so these are smaller numbers, and it is just the nature of the beast. Next slide, please. This is a detail now of our gastric cancer patients. And this is our whole team together here working, as you'll see. 42 patients, as I mentioned. This is the average age, 64. But there are people 87 years old that get surgery. There is a 20-year-old. That's a 20-year-old. Yes, that's hereditary gastric cancer, where a 20-year-old person has to get their whole stomach removed. That's significant. We do see, you see elderly patients more than 80 years old. They're candidates for surgery when it's appropriate. We have fair distribution there between sexes. And as you can see in the bottom, 75% of the patients had neoadjuvant therapy, meaning, remember when Fernando mentioned that chemotherapy is done for gastric cancer, remember all those patients with positive lymph nodes that I'm going to show you next. So this, to have 75% of patients receive chemotherapy before surgery, requires a lot of discipline from all of us in our gastric surgery and gastric cancer team, but especially from me, because, you know, as a surgeon, right, you see a patient, you want to do surgery, and you have to know that that's not the right thing for the patient, and you want to do the right thing for the patient, which is start the chemo first, do the surgery when it's your turn, and then return the patient for chemotherapy afterwards. So that's really, really, really important. Next slide, please. I don't know if I'm running out of, am I running over time here? Or am I doing okay? I think I'm doing okay.
You're doing fine. You're doing
okay. I'm almost done. I'm almost done. Here are more details on the pathology of the patients, of the patients with gastric cancer that I mentioned. And you know, I don't want to forget. I know there are some of my patients in the audience, and so all these slides are a product of their faith in us and our work at the Cancer Institute. And so I can't be thankful enough. But in any case, you see 50% of the patients there had diffuse type gastric cancer. The average size of the tumors there, 3 centimeters. Remember, 2.5 centimeters is an inch, so a little bit bigger than an inch. Look at that beautiful thing there. Complete CR means complete response or near complete response. That the chemo that was done before surgery almost killed the entire cancer. And that's where you have clean margins, and the tumor's completely out with the roots and everything, like people like to say here. And that's beautiful. I love that. You know, that number nationally is usually about 17%. So we are right with everybody else. And look at this lymph node harvest. Remember when I mentioned when you take out the gastric cancers, you need to take out at least 15 lymph nodes. So there, 19 lymph nodes average. Now, in some patients, 48 lymph nodes. So this is very important because when you do new technology, like for example, robotic surgery, you don't want to do the new technology and compromise on the principles of cancer surgery and come in here and tell me that you were getting just 5 lymph nodes out. And I know this says here that the range goes from 0. The patient has 0 lymph nodes removed was a really, really older person who I could only do a wedge resection and could not do a formal gastrectomy like the subtotal and the total gastrectomies that I mentioned before. That's an exception. But most patients here, as you can see, get 20 lymph nodes out. That's really, really important. Don't compromise on the quality of your surgery because you're using new technology. And then at the bottom there is what I mentioned before, 50% of the patients have positive lymph nodes. That's why they need chemo. Surgery alone is not enough. Next slide, please. Lastly here, some details. You know, I just want to show you, you know, this surgery is very safe. Minimal blood loss, 120 cc's of blood loss. That's not even 1 unit of blood. Only 1 patient received a blood transfusion during surgery, and only 1 patient had to be brought back for a reoperation for you know, surgical issues after the original operation. The length of stay, how long do people stay in the hospital, is about 7 days. You know, as you can see the range, so people stay 3 days. Well, there are some people, especially after the total gastrectomies, that need a lot of help and might stay a whole month. So that's what you need to see. Now, my last slide here, next slide, please. This is my stellar slide that I told Dr. Ucar I was bringing. My this slide is my favorite. This is my favorite. This is our team's performance here. Remember, we started 2018. Look, we only have 3 cases, and we've been working hard, all of us. You know, remember that not all patients get surgery. That's important to remember. I'm mentioning here, I'm bringing up here, I'm discussing here the patients who have surgery. But, you know, we see a lot more patients. Many of them never had surgery, and not because they already had advanced disease. Some people medically are not surgical candidates, and I cannot offer them surgery. So we see a lot more patients than the 80 patients that I mentioned, but at least the patients that came to surgery here, you can see how, as we have developed our team and people have found out what we do here, and not just other physicians, because we work with a very talented gastroenterology group, Gastro Health, that are super skilled, are you know, very attentive and in finding the tumors when they're, you know, they've been seen in other places and not diagnosed. And so I can't say enough about my colleagues, everybody involved here. But you can see as other physicians and patients that have done really well tell their friends, our patient volume has been going up. And I will remind you that last column in 2022, we're only in August, so the sky is the limit. We're going straight up. Next slide, please. Thank you very much, everybody, for listening to me. I appreciate it.
Thank you very much, Ramon. Excellent questions. Excellent presentation, I'm sorry. As always, surgeons still in the show with the movies. We don't have any time for questions, so we'll move to the next presentation. Dr. Santiago Aparo, he's also a medical oncologist at the Miami Cancer Institute who specializes in gastrointestinal cancers. He received his medical degree from the University of El Salvador in Buenos Aires, Argentina. He completed an internal medicine internship and residency at the Albert Einstein College of Medicine in the Bronx, where he also completed a fellowship in hematology and oncology. He is board certified in internal medicine, hematology, and also medical oncology. Santiago?
Yeah, good morning, everybody. Thank you, Dr. Ucar, for the invitation, and Thank you for Debbie's Dream Foundation for all they do and give us the opportunity to share our knowledge and what they do and for patients and finding resources and funding for research. And I share Dr. Jimenez's comments that it's a disease that doesn't always get the attention it deserves. So I will describe, this is the outline of my presentation today. I will discuss about treatment options for advanced gastric cancer. I will discuss a little bit about the clinical presentation and the symptoms patients have. What are the goals of the therapy that we administer? What are the pre-treatment studies or evaluations we do in order to target that therapy in a better way? What is the new treatment paradigm? And we'll discuss a little bit about that. It's not the same a decade ago from what we do right now to treat these patients. What are toxicities, newer toxicities? I just want to touch base a little bit at the end of the presentation about what we call next generation sequencing, which I think is very important. So what do we mean by advanced gastric cancer? So we mean when the cancer has metastasis, that means the cancer went to other organs outside the stomach. It can go to different organs, including Dr. Jimenez mentioned about going into the peritoneum, and that's how we look with laparoscopy. And it's also when the cancer is inoperable, for example, where it invades what we call vital structures that are next to the stomach that makes the surgery impossible, or because these are not structures that can be removed by doing an operation. That's not a common situation for gastric cancer in particular. So basically, we mean advanced gastric cancer when the cancer is spread outside the stomach. The symptoms patients have are different depending on the location of the tumor and where the cancer spread. But some of the symptoms could be patients have weakness, they have nausea, they can vomiting, they have indigestion, they feel that the food, they can digest food very well, they feel full very fast after eating very small amounts of food. They can have weight loss, sometimes because they don't eat because of these prior symptoms, but sometimes they can lose weight even when they eat regular meals, and they have no explanation for that. And that's sometimes the symptoms that triggers an endoscopy and consultation with the doctor, because patients lose weight and they don't know exactly why. They can have stomach pain, bloating, as I said, lack of appetite. There could be buildup of fluid in the abdomen when the cancer spreads into the peritoneal cavity in between the organs, and they can have trouble swallowing. So different symptoms that patients can present with. Next slide, please. So what are the goals of the treatment for advanced gastric cancer? And it's different from the approach we take on people who have localized disease, that the goal is to get people to a surgery and try to cure them. Here we are dealing with a disease that we're not going to be able to do surgery on. So in the great majority, not to say in all of cases, the disease, it will be incurable. And what we are trying to do is to prolong life, to palliate symptoms, meaning to try all the symptoms that I mentioned before with different treatments and interventions, try to decrease that or make these symptoms go away. That will transmit, an improvement in quality of life throughout the disease, and to prevent or delay complications. I think that's something that it's sometimes difficult to convey in the clinic when we see persons that sometimes they come with an advanced cancer and they have minimal symptoms and they think they're going to go through therapy and they're going to get worse. And one of the things we try to explain is that one of the goals of treatment is to prevent complications or to delay that as much as possible so people can keep their quality of life. Next slide. And this is, I put it in red because I think it's very important to address what are the personal goals. And this is not in the oncology books, but I think, having an honest conversation with each patient, what are their personal goals in terms of treatment? Do they want to focus on quality of life? Do they want to focus on try to prolong their life as much as possible? This is a difficult conversation. This is not something we do in 5 minutes, but I think it's very important to address this at the beginning and throughout the treatment. What are the personal goals of each patient? Next slide. So the treatment for advanced gastric cancer, I think, it's multidisciplinary. It's not just systemic therapy, chemotherapy, like I put at the beginning of my slide. I think it involves multiple services. And this is, I think, from the beginning, we need to get, it's very important for the medical oncologist, which is usually the port of entry for somebody with advanced disease into the clinic, into a cancer center. I think the nutritional support is very important. Patients come with malnutrition, they have lack of appetite, they lose weight. So to address that from the beginning, I think is important. Psychosocial support. These are people sometimes young, as Dr. Jimenez mentioned. He treated a patient who was 20 years old. Sometimes we see young patients. This disease diagnosis, they stop working, they have to pay bills, they're going to face medical bills, and they go from a normal life, fully active, fully working, sometimes the breadwinners of a family, to face this disease. And I think that psychosocial support is very important part of the treatment. Rehabilitation, do physical therapy. Patients have weakness, they have muscle loss. To work on that with a specialized team of physical therapy and rehab physician, I think is very important for patients to face treatments that could potentially be toxic. The support of family members, I think, is key because this is a disease that doesn't affect the patient alone. Patients, they don't live in a bubble. They have families, they have friends. The families will become caregivers. They're not educated. Nobody's educated about, having a cancer diagnosis or having a family member with a cancer diagnosis. So I think the support of the family is very important and for the patient outcome. Very important to manage the management of the symptoms, to involve a patient, to involve physicians who work together with the oncologist in symptom management. We are lucky in our institute to have an excellent palliative care group of doctors that they help us from the beginning, and we get them involved to treat these symptoms and to manage the toxicities associated with therapies. I think it's very important to improve their quality of life. Next slide. This is a scale about what we call performance status or functional status. It's been developed multiple years ago. We use it for different cancers, and basically it's something that sounds a kind of rudimentary in our new world with technology, molecular studies, genetic studies, but I think it's a very key and important tool that we use every day to basically guide our treatment and guide which treatment is going to be appropriate for each person. And basically, we have the both spectrums. For example, a patient who has a performance status of 0, it means a person that comes to us that is fully active, that has no restrictions, minimal to no symptoms, they are able to work. And on the other end of the spectrum, on number 4, at the end of the slide, it's somebody that is disabled, that is not able to carry for themselves, and they're confined to bed. So these are 2 different situations in which the treatments are, completely different, even though the goals of the treatments are the same, but our approach to achieve those goals is going to be completely different. Next slide. Where do we draw the limit? It's at what we call an equal performance status of 2, and without going into detail of what the slide says, basically, we can offer treatments with chemotherapy or immunotherapy for people who have symptoms or no symptoms, but they are able to take care of themselves in what we call activities of daily living. They can go to the bathroom, they can change their clothes, simple things like that. They can come to the office. And it sounds like very basic, but it's very important. I think it's very important for us to ask these questions when we see patients, because we know if patients cannot do that, and we try to push the limits and offer systemic treatments that are toxic. There's extensive body of literature that when we push those limits with our treatments, not only we don't help people, but our treatments are detrimental. So I think to draw this line, I think is very important before we decide which treatment for each person. Next slide. So as I said before, we separate patients into groups and when they have an equal performance status 0 to 2. And as I said, these are the patients who are able to carry for themselves. Next slide. And we can offer a number of treatments that goes from chemotherapy, immunotherapy, and targeted therapy. And I will go explain a little bit what each of these treatments are. And of course, we always need to the best supportive care for the patients with the interdisciplinary approach. Next. And of course, unfortunately, people who are when they're not able to carry for themselves, they have what we call a poor performance status. We should treat with best supportive care and interdisciplinary approach, but treatments to try to shrink or decrease the cancer with the other tools, it will be detrimental, and we should abstain from doing this. Next slide. So I divided the treatment in two paradigms. I think we have an old paradigm in the way advanced gastric cancer was treated for multiple decades. I would say up until a decade ago, when we started working on a new paradigm. The old paradigm was that people will come in, we will do our CT scans, PET CTs, or different imagings. We determine that the cancer was advanced, and we will offer them chemotherapy only. Different regimens, different combination of medicines. I'm not going to go into detail, but everybody was treated the same way with chemotherapy. In our new paradigm, and this is what we do nowadays, I would say we have personalized treatment, and you see this in the news a lot for cancer care, for different tumors. What do we mean by personalized treatment? It means that we try, not everybody gets the same treatment, and we have different tools for each patient. Chemotherapy being still an essential part of treatment, not always, but most of the time we use chemotherapy, but we have other tools like immunotherapy or targeted therapy. And this personalized treatment is based on molecular testing we do from the tumor. These are not genetic testing that we do to determine risk in family members or that the geneticists will talk about later on. This is molecular testing we do from the cancer cells, from the biopsies the patient get. And mainly we are looking at three different things, which is the status of HER2, the status of what we call MSI or microsatellite instability, and the status of what we call PD-L1. And those this molecular testing will help us guide the treatment for each patient. And I will discuss on what we call next generation sequence, which is a tool we have to determine these markers. Next slide. So did we make any process? Next slide. I think we did. Can you go back to the prior slide? So when we look at the old studies with chemotherapy alone, people in general live for about 8 to 9 months on treatment, on chemotherapy. Nowadays, with this new approach, with personalized medicines, people tend to live almost double that amount, 14 to 15 months when you look at the newer studies with combination of medicines. There's still a lot of work to do, but it's interesting that sometimes some of these patients, and I think we all medical oncologists have a number of patients that is not just people live for a few months, but there's some patients on these regimens that they on immunotherapy or biologic treatments that they can have durable responses, and they can be healthy, have good quality of life, and live with gastric cancer for a number of years. Next slide. In terms of the new paradigm, as I said before, we have 3 molecular markers which are important. HER2, it's in about 20% of patients who present. They will have this HER2 positive disease that allows the use of a biologic treatment. It's called trastuzumab, which is a monoclonal antibody, which is a medicine that was initially approved for breast cancer, and it's combined with chemotherapy, and it's used, and it prolongs survival in patients with gastric cancer in this particular scenario. Then we have microsatellite instability patients, which depending on the study, and this is a bit controversial, what is the frequency? But it's about, I would say, between, I wrote here based on one paper, 15 to 20%. Some people advocate that it's not so common, that is less, maybe 8 to 10%, the frequency, but allows the use of immunotherapy and no chemotherapy. And then the status that we check of what we call PD-L1, which I didn't go into the detail, but it's a score that is calculated when it's more than 5%. And this is not just a handful of patients, this is 60% of people that present with gastric cancer. We can use immunotherapy combined with chemotherapy. So very important to be able to have this information when we treat patients. Next slide. Because really, this is my busiest slide, I think. This is what we call personalized medicine. You know, when patients come in, the treatments we offer is different based on this molecular signature, I would say. So that's why it's very important to have this information before, and this is where foundations and organizations, they play a big role in advocating to do these studies fast, because this is the turnaround time for this testing is usually 2 to 3 weeks. In some cases, we are in a big center, but sometimes patients are in a small community hospital or in a private office. These studies are not so easy available to them or to the physician. So I think it's important to advocate the importance of these studies, because it really improves the outcome of patients. Patients live longer when we give the right combination, and they live better. And I give you just an example. I don't think we need to go through all these situations, but we can touch on the first one. When patients have a HER2 positive tumor and a PD-L1 positive tumor more than 1%, we offer people chemotherapy in combination with a biologic therapy, which is trastuzumab, in combination with immunotherapy. And again, this is very important, and I want to make emphasis on this, and that, you know, to have this information from the get-go, it will impact directly on patients. Next slide. We have other therapies, other drugs that were approved throughout the years. I'm just mentioning here, we have, similar to trastuzumab, an agent called famtrastuzumab deruxtecan, which is also a monoclonal antibody, which usually don't use at the beginning of the treatment, but on subsequent treatments when the initial chemotherapy or immunotherapy doesn't work. It's a monoclonal antibody also for patients who have HER2 positive disease. We have another drug that we use sometimes alone or in combination with chemotherapy, which is ramucirumab, which is a monoclonal antibody against VEGF, which is a molecular mechanism that makes the cancer grow. And other drugs I mentioned at the end of the slide, you know, tlifluridine and tiparicil, which is a pill that we can use. It's a chemotherapy agent. And then traditional chemotherapies like irinotecan, docetaxel, paclitaxel. Next slide. In terms of toxicity, you know, when we have new treatments, it's very important to be aware that there will be new toxicities that sometimes are not the traditional toxicities we see with traditional chemotherapy. So very important to get a symptom management team, typically formed of palliative care doctors, to follow patients together with the oncologist. And I think it's very important, the education of the care teams, not just the doctors who are in the office, but, you know, hospitalists, you know, advanced practice providers, nurses, about the toxicities of these drugs, you know, about the immunotherapy, about the monoclonal antibodies. And just to mention just a few on the table, for example, ramucirumab, which is a monoclonal antibody, it can leak protein in the urine. What does it mean? Why is it something that we need to detect? Because when we don't detect it soon enough, which is actually an indication to stop the drug, patients can develop swelling an accumulation of fluids in the whole body, which could be detrimental for the quality of life. So it's very important to be aware of these things and detect them early, and make the appropriate decisions to either continuation of the medicine or to stop the drug. Immunotherapy in general, it has a different conglomerate, or I would say, of toxicities, which are what we call immune-related. Immunotherapy, it's a drug that it will boost our immune system to go and attack the cancer. And sometimes the immune system gets activated too much, and that's how we see side effects. I'm not going to go into detail, but something to be aware, and people need to be educated about detecting early signs of these manifestations. For example, trastuzumab and famtrastuzumab, people can have cardiotoxicity. It's very important to detect if patients have some underlying cardiac condition. Different cancer centers, they develop what we call cardio-oncology programs. We are lucky in our center to have one of these programs, which are cardiologists. We are paired with the oncology team to monitor and to assess what are the risks of exposing patients to these drugs, but also to follow the patients over time to make sure they don't develop toxicities, and if they do, to intervene early on. And I mentioned 2 other: peripheral neuropathy for other groups of drugs, or diarrhea. But basically, very important to be educated about toxicities and to intervene early on. Next slide. One slide, as I promised, on what we call next generation sequencing. Basically, it's a new technology we have for different cancers, but in particular, it's useful in gastric cancer. It's basically a genetic map, or it gives us a genetic signature of the cancer. It gives us information about these 3 markers I mentioned before. HER2, PD-L1, and MSI, but also it has the ability to detect different mutations that will help us guide the treatment in the future. Sometimes being able to offer patients drugs are not traditionally used in gastric cancer, but if the particular mutation is present in a particular person, then sometimes it helps us guide us treatment a little bit outside the box. And most importantly, to identify clinical trials for patients. And that's how we advance the field. And I think the availability of clinical trials change, I would say, in the next few years. As I said, the paradigm change. We used to treat patients the same way with chemotherapy. So clinical trials used to be a clinical trial with a new chemotherapy regimen for everybody treated the same way. Now, clinical trials more and more are, I would say, disease agnostic in terms of what kind of cancer can be included in the clinical trial, and it's basically focused on people who have a malignancy, a cancer, and the tumor has a particular mutation, and the study is basically studying or investigating a drug for that particular mutation. So I think it's very important to access these clinical trials for patients to be able to have this information when we need it. Next slide. So my conclusions for the treatment of advanced gastric cancer, I think it's super important that we have an interdisciplinary team-based approach. It's not just the medical oncologist. It involves a whole group of people. And I think very important that most of them, or I would say all of them, they get involved from the beginning. We still performance status assessment. It's a fundamental tool to make treatment decisions. There's a change in the treatment paradigm. We offer personalized treatments now based on PD-L1, HER2, and MSI. So very important to advocate in trying to get these molecular markers early on. We have new drugs. That means new toxicities. Very important education of the clinical care team. And as I said before, molecular markers, next generation sequencing. We should advocate to be able to have these tools available. Not such an issue in big centers and big cities, but to have them readily available for the small community oncologists or people who are in smaller communities to be able to have access to and have the same quality of care that somebody would have in a big center. Next slide. I think that's the end. Thank you. Thank you very much for the opportunity, and I will take questions.
Thank you very much. Very informative. Let's try to do a couple of questions. How will this treatment affect my daily life? Will I be able to work, exercise, and perform my usual activities? Will my eating habits need to change?
Yes, and that's why I think when I mentioned on my slide, what are the personal goals? And I think it's very important that, you know, we talked about what are the positive impact of the treatments in terms of quality of life and delaying symptoms and improving, you know, prolonging life. But then, you know, it's very important to discuss with each person, you know, what it requires, what it will change, what are the toxicities, what is the schedule, how is going to affect their life, you know, how frequent they need to come to the center, how frequent are the infusions, and, you know, it depends. It's very difficult to give just one answer for that, and I think that's why it's very important that conversation from the beginning and to choose the right treatment for each person, because just to give an example, there's some treatments that we give every 3 weeks. So people take pills at home and they come for an infusion maybe once every 3 weeks. And there's some treatments that people need to come for blood work and infusions every week. That's here, right there. I mean, it's somebody coming multiple times a week for treatment versus coming once every 3 weeks. I think that's very important to discuss with each person. And you mentioned about the diet, Dr. Ucar.
Yeah, it also asks how the eating habits would have to change.
I would say that the problem with this disease is not so much, and again, there's going to be a nutritional talk later in the afternoon, and it'll touch in more detail about that. But what I tell my patients, you know, the problem with this disease is people lose weight and they can't eat, and they lose calories, they lose muscle, so they feel weak. So I tell them that the most important and the biggest enemy is the lack of eating, the lack of incorporating calories. So I try to work with them in terms with foods that they like, but also try not to skip meals. And sometimes that could be a challenge. It's not so easy. But I don't think they necessarily need to change their diet drastically.
All right, perhaps one more quick question. We're running a little over. Please describe best supportive care for patients that decide to stop chemotherapy.
Best supportive care means that we will continue treating the symptoms and concerns, but mainly symptoms, without necessarily using chemotherapy or immunotherapy to try to shrink the cancer and to try to change the biology of the cancer. But we will continue doing treatments for symptoms, for example, for pain, for nausea, for lack of appetite, and that should be pursued aggressively, not only in people who don't undergo chemotherapy, but also in people who are going through active treatment. I think it's a fundamental part of that, of the interdisciplinary team approach.
All right, thank you very much. Excellent talk also.
Thank you.
Let's try to move to the next speaker, Dr. Michael Chuang. He's a board-certified radiation oncologist at the Miami Cancer Institute. He's the medical director of the Proton Therapy Center, the physician director of the MRI-guided radiation therapy program, and the director of radiation oncology clinical research. He's an internationally recognized expert in the use of radiation therapy for gastrointestinal cancers, and he serves on several national committees, including the NRG Oncology GI Committee, and he's the disease site chair for the Proton Collaborative Group. Thank you, Mike.
Thanks so much, Tony. And thanks to everyone for tuning in today. And it's really a pleasure to be a part of this wonderful conference. And it's really, truly a pleasure to work with such a talented multidisciplinary gastrointestinal team that treats gastric cancers and others. So with that, I wanted to really focus the talk on where we've come in terms of radiotherapy and where we are now in terms of modern indications and best practices. And I thought I would start by starting with what are some facts and some myths about radiation, because radiation therapy, I think, is a not well understood treatment modality for cancer treatment. So there are a lot of misconceptions about radiation. So let's look at what is true about radiation therapy. So number one, radiation therapy fundamentally is targeted delivery of energy, and that's what radiation is, to eradicate cancer cells. So it is a localized treatment as opposed to systemic therapy like chemotherapy or other systemic therapies that go through the blood that you've just heard about. The areas that we treat with radiation are specifically designed by a radiation oncologist based on anatomic areas that are either at risk for microscopic involvement of cancer cells, and of course, visible tumor we would obviously include as well. The treatment that we deliver is not radiation to the entire body, but in fact is millimeter precise and accurate. So it is truly a localized and very accurate treatment. In general, for all cancer patients, there is some indication for more than half, whether curative or palliative in nature. And treatment times are typically, or treatment is typically delivered as an outpatient over about 30 minutes per day. The number of treatments varies from patient to patient, but most patients are treated for at least several days, if not several weeks, depending on the situation. What is false about radiation therapy? So number one is, for the vast majority of treatments, and especially those for gastric cancer, patients are in fact not radioactive, and there is no need to isolate. So there are some patients with other cancers who have radioactive implants, and that is different. But for the majority of patients, especially gastric cancer patients, there is no harm to being around other people after you get treated. So it's very much like getting a CAT scan or something like that, where you're not radioactive after the scan is done. It is not true that side effects occur everywhere in the body. So just like if you had a surgery for a stomach cancer, the side effects would be in the abdominal area. The same occurs for radiation because it is so targeted to that area. And as I mentioned before, treatment can be done with radiation for either curative or palliative intent. And we'll talk about the potentially curative implications and utilization of radiation therapy. So at the core, a very common question is, how does radiation work? And it's actually very similar to how systemic therapies and chemotherapy work, in that radiation damages the DNA of cancer cells, either directly or indirectly through the creation of what are called free radicals. The main point is that it is a DNA damage mechanism. And so the effect of radiation, just like systemic therapies, is something that occurs over time. So as cancer cells try to divide, they are unable to if they have enough damage in the DNA, and the cancer cell would die, and hopefully the entirety of the tumor would die. So it is a gradual process through DNA damage. So I mentioned before about how radiation therapy has changed, and how we deliver radiation to patients fundamentally is based on technology that exists to deliver this targeted energy or radiation to patients. And this is what radiation looked like many, many years ago, obviously very rudimentary. And these were very superficial types of radiation, very crude, not able to spare a lot of normal tissues. And these are other sort of scary looking pictures about how radiation used to be done. And this is no longer how we treat patients today. This was actually the first, what we would consider modern linear accelerator, and that is basically a term for a standard radiation machine. And the evolution now has evolved into what you see on the screen. And so we are proud at MCI to be the center with the most advanced type of radiation machines that exist under the same roof anywhere in the world as far as we know. So we offer everything from state-of-the-art linear accelerators like the TrueBeam on the left corner that you see. There's something called the Gamma Knife that we have for brain tumors. We offer a CyberKnife on the bottom right for stereotactic radiation, proton therapy. There's something called the Meridian-Lenac, Radixact, and you see a smattering of other treatments that we offer here. And so why that is so special is that we do not have to be pigeonholed into one type of treatment that if we only had one of these, of course, that would be the right answer. But since we have all of these, we can offer cancer patients what we truly believe is the best. This is how radiation nowadays is delivered. So the patient lies on a table, there's a machine that moves around them, and the radiation beam is very sophisticated, there's a sophisticated modulation or shaping of the beam that you can see here. So there are little leaves, we call them, that actually block out the radiation except for where there's an opening. And this can create very complex shapes that essentially match the shape of the tumor. And that allows us to spare normal tissues, but be very targeted to the tumor. There are advanced machines, for example, the Meridian Linac that I mentioned before, that will allow us to even see inside the body the entire time the treatment's being delivered. So you can see here, this is an outline of a tumor in the abdomen, and the machine continuously outlines this area and actually tracks the area as the patient's being treated and knows when the treatment should turn on and off based on if the tumor is in the right place or not. So truly incredible technology that we're able to now see exactly what we're treating, and this allows us to better spare normal tissues as well and decrease side effects. And last but not least, I mentioned proton therapy. This is a type of treatment that also decreases radiation exposure to the normal tissues. This is something that is mostly not utilized for gastric cancer patients, but could be. And that is, and we have the most state-of-the-art proton therapy facility, and actually the first in the South Florida region now for several years. So how do we decide between all of these types of technologies? And this was pre-COVID, of course, because this is everyone in a room. But essentially, all of the new patients that we would plan to see that day, we would review their cases in detail. And there are specialists from all over the department that we have. There's a group consensus about which machine that we should use, the amount of radiation that we should give. So this is truly a collaborative effort and a really robust discussion. So let's look at how radiation might be utilized. So this is a PET scan of a patient with the bright area is in the distal part of the esophagus and proximal part of the stomach. And so this is a patient, for example, with a localized gastric cancer. And if this patient came to tumor board, what would that discussion be? So first off, why radiation therapy for a patient who has potentially resectable disease? So the first important point, as you've heard from Dr. Jimenez and others, is that surgery for patients who have operable tumors, so tumors where there's not metastases, no spread to other organs, or if there's not a tumor that's involving a difficult area where the entirety of it probably could not be removed, surgery would therefore be the primary treatment otherwise. And in that setting for operable tumors, the question is there a possibility of residual microscopic cancer cells that could exist, that could grow and cause problems down the road? And therefore, is there a benefit of radiation as a targeted treatment? And also, of course, that's the reason why we think about chemotherapy or other targeted agents. And really, when we think about the risk, we also need to look at the risk of local recurrence, or the risk of the tumor coming back where the stomach used to be after surgery, versus the tumor coming back in other organs, other places in the body. And really the benefit of radiation as a targeted treatment to where the stomach used to be, if we're talking about giving radiation after surgery, the benefit of radiation would be in decreasing the risk of local recurrence and not really having a benefit anywhere else. And so the question is that of benefit to patients? And there are many, many studies and many trials that I won't go into just for sake of time that have looked at what is the best regimen. Is it chemotherapy alone, either before and after the surgery? Is it chemotherapy plus radiation? Ultimately, well, we'll get to the answer there. But when patients come for radiation therapy, it takes a lot of time and a lot of studying the pathologic report, the path report, and looking at the operative notes, and looking at specifically where's the highest risk for there to be microscopic cancer cells, which is the main reason we would treat patients afterwards. And there's a very complex and very involved anatomic delineation process of higher risk areas that you can see here, and that I won't go into time. But I think the point is that it's a very meticulous and anatomically driven process to design radiation therapy fields. And this is how radiation therapy has evolved. So you can see the colored lines represent where the radiation was delivered. And so the teal color sort of in the middle there is the area that we would ideally want the radiation to go to. And you can see with older machines, this is not what we deliver today, but this is really showing an evolution of how we're able now to shape the radiation beams. You can see the colored lines really match the shape of the color wash, the gray color wash where the stomach is, very, very well. So we're able to shape these beams and minimize the risk of side effects and not give a lot of radiation to the liver and to the spleen and to the intestines, for example. So that is modern radiation now. So getting back to the indications for radiation. So postoperatively, multiple trials have concluded the following: that there is in fact no difference comparing radiation alone or chemotherapy to chemo plus radiation, there is no difference in tumor recurrence or overall survival. So for all comers, there is not an indication for radiation after surgery, okay? But this is predicated on the fact that an extensive lymph node dissection was done. So we call that a D2 resection. If that is done, the clinical trials have shown no difference in a general sort of population of gastric cancer patients for overall survival. So when might radiation after surgery be indicated? So sometimes there are not optimally extensive lymph node dissections. So I would say that is very rare, but sometimes that happens for a variety of reasons. And if that's the case, there potentially could be a role for radiation therapy there. Also, after surgery, sometimes there could be a positive margin. So cancer cells seen at the edge of the specimen that was removed, that would indicate that there is potentially a higher risk for local recurrence because of that margin. And therefore, as a local treatment, radiation could potentially have a role. So that is a common reason we would, in our tumor board, discuss having a patient see us in radiation oncology to discuss postoperative radiation. These are uncommon scenarios, and I would say that the majority of patients who go to surgery, there is not an indication for those patients to meet a radiation oncologist. So we've talked about postoperative radiation. What about giving radiation beforehand? And in fact, preoperative radiation is done for many, many cancers throughout the body. And it is basically it's an unanswered question. There are a number of advantages in that we could have potentially reduced side effects, smaller treatment area, and an increased risk or an increased chance of having negative margins. But this is an unanswered question. There are several clinical trials ongoing looking at this now. So more to come on that in the next few years. But that currently is not a standard of care. Where I would say radiation probably has the most benefit is in patients with unresectable tumors, either to palliate symptoms or to delay cancer progression. Cure with radiation and chemotherapy without surgery is rare, but certainly radiation, I think, has a role. So what did the data show? So this is a study of almost 5,000 gastric cancer patients who had stage 1 to stage 3 disease, some who received chemotherapy only, some who had radiation as well. And this is a very large database that encompasses about over 80% of new cancer diagnoses in the country. And the conclusion from this was that the addition of radiation was associated with improved overall survival, and that higher radiation dose was also associated with longer survival. I think we have to take these data with a grain of salt because they are retrospective. There are no prospective randomized trials between these two, but I think that it is reasonable to offer radiation, and we commonly do for unresectable patients, in part because those patients may have symptoms. So bleeding, pain, and gastric outlet obstruction are very common symptoms. So patients who have unresectable tumors without metastases, or even those with metastases that have symptoms, will commonly be referred to a radiation oncologist here to discuss palliative radiation. And that typically is done over a few number of treatments. I would say 10 daily treatments is common, but many times we'll use fewer than that, for example, 5. And if you look at this one systematic review of almost 300 patients, the response rate from a short course of radiation was in excess of 70% to 90%, and side effects were uncommon. So in conclusion, radiation therapy is beneficial for a subset of patients, but not all patients with gastric cancer. And in fact, it's a minority of patients who have gastric cancer. But for those patients who do need radiation, the audience should be aware that we offer the most state-of-the-art technology in order to spare the normal tissues the best, to decrease the risk of side effects, and do that with the most advanced machines. And as our CEO of MCI likes to say, we have a high-tech and high-touch center here. Even though we offer the best, the most state-of-the-art technology, I'm proud to work with this group of esteemed colleagues here in terms of truly having a caring and personalized type of approach for every single one of our patients that we see. So with that, I thank you for your attention. Glad to take questions.
Thank you very much. Very good talk. So let's go to some of the questions. So the first question, is there anything I can do to prepare for my first radiation treatment?
So it's a great question. There really is not much in terms of preparation for radiation therapy. Really, the only requirement, if you will, is when we have patients who we treat in the abdomen, especially the stomach, we ask patients to not eat typically 2 to 3 hours before treatment. And that really is to ensure that the area that we're treating is consistently the same size. So for example, if someone came in and their stomach was empty one day and completely full the next day, that could move where the tumor is, and that might result in us missing the tumor on some days and treating or treating, you know, more normal tissue on other days. So other than that, there really is no preparation.
Right. So another question: can the risk of radiation affect the quality of life?
So it's a great question. And I did not speak about specific side effects of radiation, but radiation therapy to the stomach can certainly cause side effects, and predominantly there are gastrointestinal side effects like nausea. It can cause decreased appetite, sometimes affect the frequency and consistency of bowel movements, etc. So quality of life potentially could be affected because of side effects like this, and the risk of those side effects is somewhat proportional to how many radiation treatments you would need. So for example, someone receiving palliative radiation who would receive fewer treatments typically do not have as many side effects and does not have, you know, the risk of having an effect on quality of life would be much less than someone receiving more radiation for example, if the goal was to treat an unresectable tumor, if there were no metastases, and if the goal was to increase the chance of long-term disease control, we would typically recommend treatment over maybe 5 weeks, and, you know, 5 treatments per week. So that's about 25 treatments. And the risk of side effects there would be higher than if we give a shorter course of radiation. Of course, the benefit there would be a higher chance of efficacy and long-term disease control. But yes, in that scenario, there would be a more likely effect on quality of life, at least in the short term.
I think that this person was particularly concerned about radiation therapy affecting the esophageal or the gastric motility, therefore affecting the ability to eat, perhaps requiring the insertion of a tube
I see.
with normal eating.
I see. So gastric motility could potentially be affected, but it is not, that would be very rare to need a feeding tube. I don't know the last time that I've had a patient who needed a feeding tube because of that. You know, in some cases, medications might be used. In many cases, we don't need to use medications, but feeding tubes would be very rare.
Right, thank you. So there's another question. Why isn't radiation therapy indicated to reduce GIST, gastrointestinal stromal tumor, primary tumor in conjunction with targeted chemotherapy?
So that's a great question as well. You know, so radiation therapy is typically, you know, targeted agents, of course, are the mainstay of treatment. Radiation can be used in some select cases for refractory or tumors that do not respond well or that are symptomatic, and there's data to show that that can be beneficial. So in some select cases, we do think about radiation for GIST tumors, but it is not common because the other targeted therapies typically are very effective, at least up front. So it could be a backup option in a way for select patients.
Great, thank you. I think that those are the questions. Well, I have another question for you, Mike, if you don't mind. Is there any role for proton radiation for the management of any particular problems with gastric cancer?
So I'm glad you asked that. I brought up obviously the fact that we have a state-of-the-art proton therapy center previously. So, you know, proton therapy is a great treatment for many cancers. Essentially, the difference between protons and X-rays, which is what all of the other machines I showed fundamentally use to treat. The difference is that the protons will stop exactly where we want them to stop, and so therefore there's less radiation to the tissues around. So fundamentally, the benefit of protons for gastric cancers, you know, could be. So I would say that there is theoretically a benefit for gastric cancer patients because you would deliver less radiation to the intestines and to the liver, et cetera. The reason why we do not typically use protons for gastric cancer is that protons are very, very susceptible to differences in soft tissue anatomy and in the anatomy in particular. So if the stomach is different in terms of the filling each day and in the bowels in different positions, that actually can significantly affect how the doses are delivered, which is why delivering protons for abdominal tumors sometimes can be very difficult. So especially for the stomach, which is going to be different every day in terms of its size and shape and location, that is typically a reason why we would not use proton therapy for gastric cancers. But for example, for an organ like the liver, which really doesn't change very much, if at all, that's a very common indication, or other organs or other tissues in the body. So it is not routine to use protons for gastric cancer for that reason.
All right, thank you. So since we have 5 more minutes, Dr. Jimenez, a question for you. How do you decide if a patient is a candidate for robotic surgery versus open surgery? And what is the advantage of one over the other?
Thank you, Tony, and thank you for the question. Look, usually most patients are going to be candidates for either open or minimally invasive surgery. The things that come into play are a few. Number one, BMI, the patient's overall weight status, sometimes can make the minimally invasive operation more difficult. But I would also bring up as a counterpoint that those patients actually benefit the most from minimally invasive surgery too. So patients' weight status is important. Having had a lot of prior surgeries usually also burns bridges in terms of being able to do minimally invasive operations. So a lot of scar tissue can build up inside the belly from prior surgeries, and then that compromises the ability to perform the surgery with the smaller instruments and all that. And then, as I mentioned before, the tumors that are in specific locations, like again at the junction of the esophagus and the stomach, and same way the very low stomach, the pylorus, and first portion of the duodenum, you have to be careful there that if you're going to do a minimally invasive operation, it might take so long that it's probably not worth it. The benefits of the robotic surgery and of minimally invasive surgery are very, very well described. In general, there is less pain postoperatively. That allows for earlier return to normal activity and shorter length of stays in the hospital. Those are really well-established advantages of minimally invasive surgery. There are other things that go on with minimally invasive surgery, like, for example, better cosmetic result, less blood loss, and most patients will also feel less emotionally traumatized by the operation. And those are real, but a little more difficult to quantify. But yes.
All right, thank you very much. I don't know if any of the panelists has any additional comments. So I think that the presentations were very comprehensive, and I hope the audience gets a good idea about the management of gastric cancer. We're moving now towards personalized therapy and also towards a multidisciplinary approach to the management of the patients. At the MCI, for example, we discuss the new patients in our multidisciplinary tumor board to try to come up with a consensus on the best approach for managing each case individually. And also if the patients throughout their clinical evolution have a special or particular problems, we discuss the best way to solve them. I think that we're finishing a few seconds early, but thank you very much for being with us this morning. We're going to take a short break and we'll be back at 11:25 a.m. Thank you.